So thank you very much, Ernesto, for the introduction. Thank you for inviting me, and I'm happy to present this work with Andrew Glover, who's at the Kansas City Fed, and Dirk Kruger and Victor Rios-Well, who are at the University of Pennsylvania. So I hope everybody can hear me, and please just interrupt me if there's a problem. So the topic of this paper is sort of an important topic at the moment. An obvious topic is, so what is the right policy response to this pandemic that's sweeping around the world? And many countries have introduced shutdowns, lockdowns of some portion of the economy. So an important question is, how extensive should those shutdowns be, and when should they end? And a key issue that we're going to highlight in this paper, there are other papers in the literature that have looked at this topic too. Key thing we're going to highlight is that there are big distributional implications of these lockdown policies. When we think about the virus, we know, one thing that's special about this COVID-19 virus is that it's very dangerous for older people, and serious health conditions and deaths have been heavily concentrated amongst the old. So key benefit of trying to slow down the spread of the virus by shutting down parts of the economy is to try and protect especially older, more vulnerable people from the virus. So those are the benefits. The costs of these economic shutdowns, on the other hand, those are going to be mostly borne by younger workers, who are the ones who are actually working, and especially those who are in sectors of the economy that are likely to be shut down. Those are the ones who are going to face potential risk of being unemployed. So think about a world like this. It seems like, yes, we probably want some form of a shutdown. And at the same time, we want to have some redistribution towards those who are losing their jobs. So that's what we're thinking about. Okay, so what we're going to do, we're going to build a model which has sort of an epidemiological side, which is going to be probably familiar to you if you've seen some of the other papers floating around. And it has an economic side in which there's some heterogeneity. In particular, people are going to differ by age, and they're going to differ by sector. And we're going to allow a planner to choose how long the shutdown should be and how extensive it should be. And also the planner is going to choose how much resources to transfer towards people who are not working. And those transfers are going to be expensive. And so we're going to think jointly about the planner choosing the mitigation policy. Mitigation is the word we're going to use for the shutdown, how extensive and how long the shutdown is. And then the planner is also going to be choosing how much to redistribute towards those who are losing their jobs. We're going to think about optimal policy, and we're going to be in particular interested in this interaction between these two policies. So on the one hand, this mitigation policy, shutting down part of the economy, that's going to create a need for more redistribution towards those who are losing their jobs. On the other hand, if this redistribution is costly, kind of understands that it's going to burn up some resources if it tries to redistribute. That's going to temper the planner's appetite for mitigation. So maybe it's going to want a little less mitigation. So we're going to be thinking about those sorts of trade-offs. Okay, so that's like a little bit high-level introduction, and now I'm going to sketch a little bit the health side of the model and then the economic side of the model. So the health side is a variant on a standard SIR model, the susceptible, infected, recovered model. So that's a model that you've probably seen at this point. So there are people running around who are susceptible, who haven't been infected by the virus yet. That's the S group. Then there's the infected group, who are the ones who are actively infected and can pass the virus on to other people. And then the recovered group that have had the virus. And we're going to assume that once you're recovered, you can't get infected again, and you can't pass the virus on to anybody else. So we're going to start with that, but we're going to sort of break this infected state, this middle state, into 3 substates. So we're going to call it like the safer variant of this model. The susceptible stage is as in the standard model. And then when people are first infected in our model, we're going to assume that they are asymptomatic. So they are infected, they can pass the virus on, but they don't have any symptoms. Or perhaps they have very mild symptoms. They're not quite sure if they have a cold or if they're something more severe. So this group this group is it seems like, we're learning more and more that there is a large number of asymptomatic cases of COVID-19. And this asymptomatic group is a little bit dangerous because they're not aware that they have the virus and they could potentially be passing it on to other people. Then you can, once you're asymptomatic, you can potentially develop more serious symptoms, a fever, a flu-like symptoms, and call that the F state. And there you realize that you're sick, you have the virus. If you're unlucky again, you can develop even more serious symptoms and need to go to hospital. That's the E state, where you're in emergency care in hospital. And then the last state is going to be the recovered state, or potentially, you might not recover, in which case you're dead. So the worst case progression for the virus in our model is going to be from susceptible to asymptomatic to flu to emergency care to dead. But we're going to allow people to recover from the virus at any of the asymptomatic stage, or the flu stage, or the emergency stage. So in particular, there's going to be some people who they contract the virus, they don't have any symptoms, so they're just asymptomatic, and then they recover, and at that point they're immune, but they might never realize that they were infected. So there are some people running around who've had the virus and they would show up on an antibody test as positive, but they might not realize that they were ever infected. Okay, so the reason why do we go to the trouble of kind of having these three different states? Well, we're going to think about them spreading the virus in different ways. So the asymptomatic group who don't realize they're infected, they carry on with life as usual, and they can spread the virus at work, in market consumption activities, and at home. Those with flu-like symptoms, they realize they're sick, and we're going to assume in our model that they don't go to work, they don't go shopping, they stay at home, so they can still potentially infect other family members. The ones who are in the emergency state in hospital, they can potentially pass the virus on to healthcare workers, but that's the only group they're going to infect. Okay. Now I'm going to describe a little bit, a high level, the economic side of the model. And here we're going to have, it's a very simple stylized model. So I think, you're going to see many places in which we could probably have kind of added a little bit more richness and a little bit more realism. But we wanted to kind of bring out what we thought of as some of the key trade-offs and some of the key dimensions for heterogeneity in the simplest way we could. So for age, we're just going to have two groups, young and old. And the young, we're going to think of as everybody less than 65, and the old is everybody over 65. Okay, so the key difference between young and old, only the young are going to work. So the old, we're thinking of people who are retired, so they're not going to infect people at work. The old are going to have much more adverse health outcomes, conditional on getting infected. Young, on the other hand, maybe have a higher chance of getting infected because they're the ones who are interacting more in the workplace. And in terms of their preferences, we're going to assume they're sort of symmetric, except that the old are going to discount future utility at a slightly higher rate, reflecting the fact that they have shorter remaining life expectancy. Okay, so that's young and old. And then within the young, there are going to be two sectors of the economy. There's what we think of as a basic sector and a luxury sector. Or you could think of them as an essential sector and a non-essential sector. So the basic sector, we're going to think of that as the parts of the economy that seem sort of pretty essential to day-to-day life. And so the idea is that the planner is never going to want to shut down any of the basic sector. So think of healthcare, food production, law enforcement, some basic functions of government. So that part of the economy is never going to be shut down. That's also going to be the sector of the economy where workers in that sector are going to be the ones who take care of the sick. And then the rest of the economy, we're going to think of as the luxury sector, restaurants, entertainment, manufacturing, for example, we're going to think of as part of the luxury sector. And the government is going to be thinking about what fraction of that sector to close down. Well, M is going to be our variable that denotes the mitigation policy, and M is going to be the fraction of this luxury sector of the economy that the government closes down. And it can choose how much to close down, and it can have that fraction vary over time in a particular way. So we're going to talk about how that might vary over time. And our young workers, they're going to have stamped on their head, they're either going to be assigned to the basic sector or the luxury sector. So if you're a basic sector worker, you're stuck in that sector. You're never going to be mitigated. You're never going to be asked to stay home. If you're a luxury sector worker, then there's a chance that you might be assigned to stay home and be unemployed. And that's going to depend on the fraction of this sector M that the government shuts down. Okay. So that's that sector. Maybe I just pause for a second and ask if there's any questions so far about this part of the setup.
So if there is any question, please write in the Q&A your interest to speak. I think we can keep going.
Okay, good. So here's like a little bit some of the trade-offs. So if you shut down part of the luxury sector, then people aren't interacting as much with other co-workers because they're staying at home. So that's going to reduce contagion. It's going to reduce the risk of hospitals becoming overloaded. So we're going to model that in a very simple way. But obviously, if you ask people to stay home, you're going to produce less output. So average output and consumption are going to be reduced. And you're going to increase inequality in the economy because there's going to be more people who are unemployed and have no income. And they're going to have, in our model, they're going to have lower consumption because it's going to be costly for the planner to redistribute resources towards those guys. So those are going to be some of the basic trade-offs. This redistribution, well, the planner, there are some people who are retired, some people who are sick, some people who are unemployed, and the planner is going to be able to make transfers to all of those groups. That's going to, make the planner a little bit more willing to mitigate part of the economy, but it's going to be expensive. So we're going to think about what sorts of policies different types of people in this model would like. What would the old prefer? What would be their optimal mitigation policy? What would be the young optimal mitigation policy and the young in the basic sector versus the luxury sector? And if we think of a utilitarian planner who sort of puts some weight on everybody, what would that planner choose?
Jonathan?
Yes.
There is a clarification question.
Yes.
Benjamin Garcia is asking, do people live alone here? Or in other words, can young people make their parents sick?
Yes, so I'm going to describe that. The idea is going to be, yes, they can. There's going to be, we are going to model, we're not going to model sort of people living in families directly, but we are going to think of the home as one of the places where the disease gets transmitted. We're not going to have enough detail to sort of keep track of who is related to whom and keeping track of infections at the family level, but we are going to think of infections within the home as part of that. So I'm going to describe that in a couple of slides.
Thank you.
Okay. Okay, so here's a kind of preferences for the people in our model. So they have it's a continuous time model. So they have they discount at some rate rho, and that's where the differences are going to show up between the young and the old. The old are going to have a higher time discount rate. That's just going to be a very simple way of thinking about the old having a shorter remaining life horizon. And then there's going to be some standard concave utility over consumption, this U of C function. And that's going to be the same utility function. Actually, it's just going to be log consumption. It's going to be log consumption for the young and for the old. And then there's going to be two other additive terms, U bar and U hat. So U bar is just going to be a flow value you get every period as long as you are alive. And U hat is going to be some extra flow value you get that's going to depend on your health status. So the reason for putting this U bar thing into the model is that you think about trying to slow the spread of the virus. The payoff is going to be you're going to have fewer infections and fewer deaths. So you have to take a stand on how much people value being alive relative to the risk of death. And this U bar parameter is going to be sort of controlling the level of utility you get when you're alive. When you're dead, this U bar is effectively 0. So if U bar is a really big number, you're going to be willing to potentially sacrifice a lot of consumption in order to reduce the spread of the virus and reduce the risk of mortality. So that's the importance of the U-bar parameter. And then U hat is just going to be some extra kind of utility flow piece you get depending on your health status. So we're going to think in particular that if you get sick and you've got a flu or you're in hospital, that's not fun. That's going to reduce your flow value of utility whilst you're in that state.
Jonathan?
Yes.
There is more or less more conceptual question. So I'm going to open the mic for Fernando Toro. 1 second, please. No, Fernando, you can speak.
Yeah, thank you. Thank you, Ernesto. Jonathan, hi. My question is if you have heard about the exoma theory.
I'm not sure I have. The external theory, is that what you said?
Exome theory. The theory.
No?
It's about the virus is not, the behavior of the virus is not like a virus. It's an infection that affects the cells, not like a virus. If you heard about that theory.
I don't think I have heard about it, but
okay. Okay.
Do you want to maybe I'm going to describe how the virus works in this model, and then maybe you can tell me how you would model it differently if you think it's
okay. Okay, thank you.
Okay. Okay, so those are preferences, and then now the technology, the producing output is very simple. So these young workers, they're either stuck in the basic sector or the luxury sector. They can't switch sectors, and we're going to assume that they're all equally productive, all these workers. And so output is just going to equal the number of workers. There are no other factors of production, no capital. We're thinking of this whole pandemic as lasting only, say, a year or so. So capital over that horizon of time doesn't seem like it's going to be moving very much. We're going to say, well, who's going to work? It's only going to be the workers who are either susceptible, asymptomatic, or recovered, because the ones with flu or ones in hospital, they don't work. So the output of, say, the basic sector of the economy, YB, that's going to be the total amount of output produced in the basic sector, is just going to be the total number of workers in the basic sector who are in those three health statuses. So the notation here, X is sort of like a measure of the population share, and the subscript Y stands for young, B for basic, S for susceptible. So XYBS is the number of young workers in the basic sector who are in the susceptible health status, haven't been infected yet. So I add up the number of workers who are susceptible plus asymptomatic plus recovered. That's the total number of workers. That's just the total output in that sector. The output of the luxury sector is the same, except that now the planner potentially is going to ask some fraction M of those luxury sector workers to stay home. And so the output is going to be reduced 1 for 1 for every worker that the planner asks to stay home. Actually, later I'm going to show you an extension where you can imagine somehow, suppose the planner had, suppose you had widespread antibody tests, and you could test everybody and you could figure out everybody who's recovered in the economy. They've already had the virus, so you know that they can't pass the virus on anymore. You could say, well, those guys, I'm never going to ask them to stay home. They can always work. So that would be a smarter mitigation policy. I'm going to talk about that briefly later. That would be a better way to mitigate. Now, the total output of the whole economy, we're just going to assume for today that it's just the sum of the output of these two sectors. And we're going to assume the outputs of these two sectors are perfect substitutes. And that is, that's obviously a restrictive assumption. It's going to make the model very tractable, but you might think that these outputs of these two sectors are imperfectly substitutable, and that would be, that'd be an interesting extension to think about. Okay, so then there's some amount of output is going to be used for emergency healthcare. We're just going to keep track of that. It doesn't play much role in the model. It's going to play an important role on the health side of the model, but we're going to see this total output here. Some of it is going to be used for financing emergency hospital care. And so it's going to be the rest that's going to be available for consumption. And now I'm going to talk about how the virus transmits through the economy. And this is maybe where, I guess we're learning about the nature of this virus, and we're learning more and more over time about how it transmits. And so this is a part of the model that obviously we could improve as we learn more. So we're going to think of the virus as being passed on in 4 different places. One is in the workplace. So there are going to be some young workers who are going to run into coworkers who are asymptomatic. So they have the virus, but they don't know it. So they don't know any better. They show up to work, and they're going to pass the virus on at some rate, beta W. And I'll describe more what beta W is in a second. And then the second place where transmission occurs is in market consumption activities. So you go to a bar or a restaurant, and there are some other shoppers that you run into in the store or in the restaurant. And if some of them are infected, they can potentially infect you. So that's going to happen at rate beta C. The third place that you can get infected is at home through family members or friends, or think of the home more broadly as any non-market activity. And at home, you can run into people who are both asymptomatic and people who have the flu, who are infected with and have more severe symptoms. So the chance that you get infected if you run into somebody who's infected at home is beta H. And then lastly, there are going to be some of the basic sector workers who get infected taking care of the sick in hospitals at rate beta E. One little detail that we thought about, and we have modeled it, but in a fairly simple way. You could think that within different sectors of the economy, say within the luxury sector, there are a whole range of different subsectors, and some of them are more social contact intensive, and some of them much less so. So to say think about different sorts of stores, there might be, say, an online bookstore where there's literally no person-to-person contact whatsoever, and so there's no chance of getting infected through ordering your book online. At the other extreme, there's a rock concert where there's lots and lots of people there. There's a really high chance that if you show up to work in that sector, you're going to get infected. So we're going to think about that heterogeneity in a very simple way. We're just going to imagine that there's a uniform distribution of these infection-generating rates across different subsectors. So this is a little bit of a detail, but that's why we have these infection-generating rates, beta W, depend on the level of mitigation. So the average level of mitigation is going to be alpha W. That's the average infection-generating rate at work. And what we're going to think about is that if the planner decides it's going to shut down, say, 10% of the luxury sector, the subsectors it's going to close down first are going to be the most dangerous ones. It's going to start by closing down the rock concerts, the cruise ships, the bars, and then later it's going to close down the bookstores and the other sectors that are much safer.
May I ask you a question there?
Yes.
But if there's this multiple sector setup for the luxury sector, households or workers, they don't work in a complexification across all sectors. Probably they work only one of those. Or
yes,
if we think about a household with many family members, a few number of those. So getting shut down 10% of the luxury sector is not the same that 10% of workers cannot go to work because their luxury sector is being completely shut down. Distributional things, in distributional sense, those things are different, right?
So we're gonna think that what happens in the way the shutdown works is that the planner tells it identifies the sectors it's going to shut down, and then all the workers in those sectors are going to get sent home. So they're all going to be unemployed. And the workers in the other sectors are going to work as normal. So there's going to be, there is going to be heterogeneity. I mean, it's not that everybody's going to get their hours cut by 20%. Does that make sense, or are you asking something different?
Yes, that makes perfect sense. Thank you.
Okay, so here are the infection generating rates, And this is the, I mean, there's a little bit of a long equation, but just to talk through this one, this is the most important one. So we want to keep track of the flows of people between these different health statuses. So these equations here tell us how many people are flowing into the asymptomatic state, how many people are becoming newly infected and they're moving out of the susceptible state. So we have on the right-hand side of the top equation, XYBS, this is the number of people, young basic sector workers who are susceptible. And we want to figure out how many of them are becoming infected. So they can become infected these 4 different ways. The first term in the square bracket tells us how many of them are becoming infected through co-workers. So the number of infections from co-workers, the number of these susceptible workers who are going to work, XYBS, times the number of people at work who are asymptomatic. So the number of asymptomatic workers is the number of basic asymptomatic workers plus the number of luxury sector asymptomatic workers, except that the planner has told fraction 1 minus m of those luxury sector workers to stay home. Okay. So the total number of meetings is going to be the product of the number of susceptible basic workers times the number of asymptomatic workers in the economy. That's the number of meetings. The chance that any of those meetings translates into a new infection is beta W. Okay, so that's going to give a flow of new infections, and those susceptible workers, that fraction of them are going to become asymptomatic infected workers. The second term in blue, this is the number of people who are getting infected through market consumption activities. That's going to depend on the infection generating rate through market consumption beta C. And we're going to assume that it's proportional to the amount of output in the economy. So the idea is that the total output, imagine that, say, the number of stores that are open in the economy is proportional to the level of output. Imagine everybody visits every store in the economy. If you shut down some portion of the economy, there's fewer stores to visit and a smaller chance of becoming infected. So, no, obviously there are a lot of different possible choices you could make in terms of writing down these infection generating rates, and it'd be nice to have a lot more sort of micro evidence on exactly how these infections arise. I'm going to talk a little bit about some empirical evidence in a second, but the precise functional form is something you could experiment with. And this third term here is going to be how many people get infected at home. So there's some basic susceptible workers. At home, they're going to meet people who are both asymptomatic and people who are suffering from flu, young and old. So that's going to be the total number of meetings is the product, and the chance that any one of those meetings results in infection is going to be beta H. And then the young basic workers, they can also get infected taking care of the sick in hospitals at rate beta E. So that's the kind of infection rate for the basic young susceptible worker. The luxury one is sort of similar, except that these luxury sector workers, they don't get infected at work quite as much because only fraction 1 minus m of them actually go to work. If m was 1, so you told every single luxury sector worker to stay home, then none of them would obviously get infected in the workplace. And the old, this is the last line, the old, well, they don't work at all, so there's no infection at work for this group. So you think about, how mitigations and shutdowns can slow the spread of the virus. Well, firstly, you've got fewer people working, there's less workplace transmission. Secondly, if you reduce output in the economy, you reduce the number of stores that are open, there's going to be less consumption transmission. But these shutdowns aren't going to directly impact home or hospital transmission. So that's how people become infected. And now I'm gonna I can page down. So this is how they flow from these other health statuses. So these equations look a little. There's a lot of notation, but they're sort of simple to think through. So this first line here says, let's take one type of worker, say a young basic sector worker. I have some number of them who are infected but asymptomatic. They're in this asymptomatic state. How many new asymptomatic cases do I get? Well, firstly, there's a flow into the asymptomatic state from the susceptible. That's the equation I just showed you. So some of the susceptible types are becoming infected. That's the flow into the asymptomatic state. Then there's a flow out of the asymptomatic state. And how do you get out of that asymptomatic state? Well, either you develop more serious symptoms, you develop flu. That's with probability sigma JAF. Or you just recover with probability sigma JAR. Now, people having flu, similar. There's a flow into the flu status from people who are asymptomatic with probability sigma JAF. They develop flu. And then there's a flow out of the flu status. Some of them develop more serious symptoms, need to go to hospital. Some of them recover. People in hospital, same thing again. And then people who are recovered, well, some people can be recovered from the asymptomatic state. Some people are recovering from the flu-like state. And some people are recovering from hospital care. Now, this last piece here, this recovery from hospital care, here we're gonna think about this thing that people have talked about a bunch, which is this idea that you have to be very careful not to overload the hospital system. Because if you don't have enough ventilators, I think ventilators were a concern early on, maybe not so much anymore. But the thought was if you don't have enough hospital beds, you're going to get a lot of excess mortality in hospitals. So that was why it was one reason it was important to try and flatten the curve and kind of protect the hospital system. So the way we're going to model that is we're going to think that the hospital system has some number of beds, some capacity theta. If the number of people in hospital, XE, exceeds the hospital capacity, we're going to imagine there's some excess mortality given by this, this rate B that's going to depend on the parameter lambda 0. So the more you exceed hospital capacity, the lower is the recovery rate from hospital and the higher is the death rate in hospital.
Jonathan?
Yes.
There are a couple of questions.
Oh, yeah.
One is from Benjamin Garcia. It's a kind of long to read, so I'm going to open the mic for Benjamin. Benjamin, you can speak now.
Okay. You hear me?
Yes, I hear you.
Is that about the consumption-related risk? One might think that this risk is proportional not to shopping quantity, but shopping trips. And that as people know the risk of getting infected, they might trip. I mean, there's some anecdotal evidence about that. And those will reduce the proportionality with consumption. And I wonder if something like this is feasible to incorporate because you may be overstating that thing.
Yes, so that's a good question and something I should have mentioned a little bit. So if I look at these infection generating rates, now there are these parameters like the beta H parameter, and then these other parameters alpha W, and there's going to be an alpha C parameter that kind of those are the fundamental parameters that determine how much infection you get through these different activities. Now, as you say, I mean, I think you make a good point, and there's a point that that others have thought about too. That once people realize this virus is spreading around, they are going to change their behavior, and they're going to take more caution to avoid getting infected. So they're going to be smarter in their shopping. Maybe they're going to make fewer trips, buy more each time. Maybe they're going to try and shop online more. When they go to work, they're going to wear a mask. They're going to try and stay away from their coworkers, not go to the cafeteria for lunch. So we're going to think that all of those changes in behavior are going to change these. When people first become aware of the virus, they're going to change these changes in behavior are going to change these fundamental technology parameters, the alpha W, the alpha C, and the beta H. And so when we calibrate the model, we're going to think that right around, for the US, we're going to think about, say, March 21st, when people are sort of suddenly realizing how serious this is, that there's a kind of a one-time shift in all of those parameters. And we're not going to model it in a very sophisticated way. We're just going to think there's a, that's what we have in mind, but we're just going to model it as an exogenous shift in all of those parameters.
We have another question from
Yeah.
Sofia Boduco. I'm going to open the mic for Sofia. You can speak now.
Yes. Hi, Jonathan. It's a very, very small question. So I don't know if I got lost a little bit, but you cannot go from susceptible to the hospital directly, right? You have to go through the stages of the disease.
Yes.
Does it matter at all? I'm just saying, I'm just thinking that we get the stories of people arriving at the hospital in a very, very, very bad shape. And I don't know if that matters for the results at all.
No, I think that you could imagine that people can, you can imagine that there are more sorts of transitions are possible in the model. We have said, yes, I think there is some evidence that for pretty much everybody who becomes infected, there is a period where they are contagious before they realize that they are contagious. Or maybe they start having some mild symptoms, but they're not quite sure. Maybe it's just a cold, maybe it's just regular flu, maybe it's hay fever or some allergy, and they don't immediately self-isolate and quarantine. So there is, I think there's a question how long that is and whether you're equally contagious in that state as you are when you have full-blown symptoms. So there's a lot of stuff we still don't know about that. But I think, yeah, I think for most people there is a progression from through these different health statuses. And if you do end up in hospital, it's not like you were perfectly fine 1 second and the next second you are unable to breathe. I mean, I think it. So there is a progression, and in this model, we're going to calibrate so there's an average kind of duration of each of these phases. So we're going to have, you're going to see in a second, this asymptomatic stage is going to last 5 days on average. I think the flu stage on average lasts 10 days or something like that. But those are averages, and this is just these things happen at a sort of Poisson sort of exogenous rate. So there's going to be some people who transit very fast and some people who transit very slow. So we are going to get some cases where people, within a very short period of time go from being totally fine to hospital. There's going to be some of those, and there's going to be some that so much longer. Did that sort of answer your question?
Yes, perfect. Thank you.
Yeah. Okay, so now the last piece of the model that I'm gonna tell you about before I talk about the data and the results we get is about this redistribution. And so we're gonna think that there's the planner understands that there's some people out there who are working, they have income, and then there's another group of people who are not working. And those are the old who are retired, the people who are sick, who have flu or in hospital, and the people who the planner has asked to stay home through their shutdown policy. So the planner is going to want to make some transfers from the first group to the second group. We're going to imagine that a planner that is, say, utilitarian. So the planner cares equally about all of these non-workers. So what this planner is going to want to do is give all the workers one consumption level, CW, and all the non-workers at different consumption levels, CN. If you didn't like the utilitarian assumption, you could just say, well, I can't really tell whether somebody's not working because they're sick or because they've been told to stay home. So I'm going to have to give them the same consumption level no matter what. Okay, so we're going to have some people who are working and some people who are not working. Mu n is just going to be the number of non-workers, mu w the number of workers. And we'll just have to count up across the people of different age groups and different health statuses to figure out how many people there are in each of those groups. Aggregate resource constraint is this line here. So I have mu w is the fraction of workers, CW is the consumption I give to each worker, mu n the number of non-workers, and Cn how much I give to those guys. Then there's going to be this term with T in it. This is going to be the cost of making these transfers. So we're going to assume that there's sort of a dead weight resource cost of making transfers. And it's going to depend on how many transfers you want to make, how much resources you want to give to these non-workers. That's going to burn up resources. The total amount of resources you have in the economy is the amount of output you're producing, Y, minus the amount that you're using to keep the hospital system running. So this is the theta, remember, was the number of hospital beds you have, and eta is the cost of running each of those hospitals. Now, how much output do you produce in our simple model is just how many people are working. So it's just the number of workers. Okay. So this planner has got to choose these two consumption levels, respecting this resource constraint. And the planner is going to want to know, well, what is this cost function for reallocating consumption across? So the nice thing about this problem is that the way we have set it up is that this consumption allocation, how much consumption you give to these two different groups, is not going to affect the progression of the disease. So this redistribution problem is going to be a sort of a static problem. Each period, there's a planner. It knows how many people have been told to stay home, how many people are sick. It knows how much output is out there. And it's going to be just a simple static problem to figure out how to divide that output between the workers and the non-workers. Why is that the case? Well, it's because if you remember those disease progression equations, the rate at which people become infected, it depends on the total level of output in the economy, but it doesn't depend on how that output is divided between these two different types. So this planner, this static problem, the static redistribution problem, there's a planner that's maximizing average welfare. This is the kind of average welfare expression. UW is the fraction of workers, log of CW is the utility they get from consumption, mu n, the number of non-workers, how much utility they get. All these people get this flow utility of being alive, U bar, and then there are these kind of different health status flow utilities, U hats, that the planner has to take into account, but those don't depend on the redistribution policy. And the planner is just trying to maximize this average static period utility subject to this single static resource constraint. So there's a straightforward first order condition that says the planner is going to allocate consumption of workers relative to non-workers, and it's going to depend on the marginal cost of giving the consumption to these non-workers. The way we're going to parameterize that is we're going to think about this transfer cost function as being quadratic. I'm going to tell you a little story for that. So the functional form is going to be this one in particular. So we're going to think there's some exogenous parameter tau that's going to tell us how costly redistribution. That's going to be the parameter that controls how costly redistribution is. If I want to give the total cost of this redistribution is going to depend on how many resources I want to extract from every worker. So the amount of resources I extract from a worker, if I'm giving Cn consumption to mu n non-workers, that's the total amount of resources I've got to raise through taxes or through some other scheme from the workers. Mu w is the number of workers. So this ratio inside these brackets is the effective amount I'm taxing each of these workers. And I'm going to imagine that the cost of these transfers is going to be quadratic in that amount that I'm extracting from each worker. So the thing we have in mind is that if you think about, say, redistribution through taxation, if you want to extract a little bit through the tax system, low tax rates aren't very distortionary. If you try and extract more and more in a richer model with, say, endogenous labor supply and so on, those distortions would become more and more costly, and the marginal cost of extracting more and more resources would grow. So we just model that in a simple parametric way with this quadratic function, and then we can solve in closed form for the optimal allocation of consumption for workers and non-workers. And the key properties of this optimal allocation is that the amount that I want to give to the non-workers is gonna the cost of making these transfers is going to increase with tau, which is the exogenous parameter showing up in this cost function. And the amount of making the transfer is going to increase in the amount that I try to transfer. So I want to have very generous transfers. It's going to be more costly. And the cost is going to increase. It's going to increase with the share of non-workers. It's going to decrease with the share of workers. So the idea is if I have a lot of people who are mitigated, a lot of people who are staying home, then I'm going to have to finance all of those stay-home workers' consumption by taxing a very small number of workers. So I'm going to have to tax all those workers at a high rate. That's going to be distortionary. That's going to be very costly in redistribution terms, and that's going to make the planner choose to redistribute a little bit less. There was a question, yeah.
Yes, there are a couple of questions. One is Mario Gonzalez. who is asking about whether you guys have considered another form of utility for the planner. For instance, minimization of the change in the earnings before and after the start of the disease.
Minimization of the change in earnings.
The difference between, yes, or the difference in earnings before and after.
Well, what we have done is, I can tell you what we have done. We're gonna consider a few different cases. We're gonna consider a case where this redistribution is costless, so the planner can always redistribute at no cost, and then the planner is always going to want to give the workers and the non-workers identical consumption. That's going to be one case. And we're also going to look at the policy that the planner would choose. Suppose the planner only cares about the old, and so the planner is just going to do exactly what policy the old would prefer. We're going to look at that. Or we're going to say, well, what policy would the planner implement if he only cares about the young, and so he implements the policy that the young most favor. So those are the ones we're going to do.
Okay, another question is from myself. I want to ask you whether the cost of the transfer may encompass the financing of the transfer through debt.
Yes, I think so. So I think if you think about the, say, the US, what is the US doing at the moment? So I think the key policy in the US has been a huge expansion of the unemployment insurance system. So in particular, they've changed the rules so more people are eligible. And for everybody who is already eligible for unemployment insurance, everybody is now getting an extra $600 a week in unemployment benefits. That's just a huge extra benefit in the US. If you work 40 hours a week, $600 is an extra $15 an hour. So it's as though on top of your previous benefits, you're now getting an extra $15 an hour when you're unemployed and at home. So that policy, there are distortions associated with that. And one of them is that there are businesses now that are, say, trying to open up like a little coffee shop, and they pull up their workers and ask them, will you please come back to work? And the workers say, well, actually not really, because I'd rather stay home, because I'm actually making more money at home collecting unemployment benefits than I would if I went back to work. So those sorts of distortions that people choose not to work, and therefore the amount of output that the economy can produce is reduced. Those are the sorts of distortions we have in mind. There were also, so those are on this, there were also distortions just on the financing side. For example, if you finance this by taxes, then you're gonna people are gonna work less. If you finance it through debt, as you were suggesting, well, that's also going to be distortionary. People are going to expect higher taxes in the future, and this debt is also maybe going to crowd out investment and have other effects on the economy. So all of those things loosely are what we kind of trying to think about in terms of this cost of redistribution. And we're doing it in this kind of simple way that's a little bit stylized, and it's kind of hard to think about how to map that into actual taxes or debt policies. But the thing that we are going to be measure is, if you think you have an idea of sort of the optimal level of redistribution, then you can sort of, this model is going to have an implication for how much consumption you want to give the workers relative to the non-workers. And that's sort of what we're going to try and map to in the data. So a long answer, I'm not sure it was a, yeah. We don't really have, it would be nice to think about taxes and debt more explicitly, and we don't really have that. In our model, people either work or they don't work. So there's no sort of intensive margin of labor supply. And so it's not really a natural setup for thinking about distortionary income taxation, for example. Okay, so now I'm going to talk about the data. So this is going to be obviously important and maybe a little bit more. Some of these components that would apply to any model, not just to ours, but I'm going to tell you the things we have to think about, and later a little bit how different inputs are going to change the answer that you get. So utility from consumption, we're just going to go logarithmic. The young, as I said, are going to be those below 65. That's about 85% of the US population. So they're the bulk of the population, the old are over 65. The two discount rates, we set them for the young to 4%, the old for 10%. And we have in mind there that the old naturally have a kind of, even without COVID, they have a shorter remaining life expectancy. We're not going to model natural death explicitly. We're just going to bake that into a higher discount factor. And there was this U-bar parameter that I was talking about. So what is the flow value of being alive? It's an important parameter. There's a literature that estimates this thing they call the value of a statistical life. And say the Environmental Protection Agency or the Department of Transportation, they use these numbers to figure out whether it's worth, suppose there's a road intersection, you can spend $10 million to make the intersection a little bit safer, and you expect to reduce the number of traffic fatalities by, say, 1 death. You know, is it worth spending the $10 million to do it? So they have a value of a life that they attach to that. The EPA and the Department of Transportation, they use a value of $11.5 million in the US. Translating that into a flow value, that's $515,000 a year, which is about 11.4 times US consumption per capita. So that's the value we're going to use. And to give a kind of a little bit of a flavor of what that means, you can say, suppose I just have a purely static calculation. And I think about how much consumption would I be willing to sacrifice forever to avoid a 1% chance of dying today? And the answer you get if you have this $11.5 million value is, well, I'd be willing to give up about 11% of consumption to avoid a 1% chance of death. Or here's a different example. Suppose you think about, maybe this is an example a little bit more relevant for COVID. Suppose you think about giving up 25% of consumption for 6 months. How much would I have to be reducing my chance of living 10 more years for that to be a worthwhile sacrifice? Well, you'd have to be increasing your chance of living another 10 years by 0.16%. This is this value of statistical life. It's an important number, obviously, and this is a high number. Other countries use smaller numbers. European countries, for example, use smaller numbers. Then these flow values for being sick or being in hospital, we're going to say, well, if you've got flu, that reduces your baseline utility 30%. In hospital, reduces it 100%, just while you're in hospital. Then we have the parameters, all those sigma parameters that control the rate at which you transit between these different health statuses.
Jonathan, sorry about
Yes.
it. There is another question. Benjamin Garcia is asking about whether the 65 plus are a percentage of the total population. It's a calibration question. Probably more relevant using the percentage of the 18 plus population, assuming that younger than 18 or about 20% of the population don't work.
Yeah, so that is a good question, and I think that we think of the under 65-year-olds as everybody from age 0 up until age 65. We do think of them all as working, so I guess we haven't explicitly thought about the issue that people under 18 are not working. So we haven't modeled children explicitly in this model. That's a group, I guess, that's a third group, or not working, but I guess we think of them somehow as living with their parents, and so we don't think of that as a group that you have to redistribute to. The government doesn't have to do that kind of redistribution that happens within the family. Is that sort of the question? We should think about that a little bit more, I think.
I think so.
Yeah. So these health transitions. So the first one is, well, of the people who become asymptomatic, initially infected, how many of them actually immediately recover and never know that they were ever sick? And that is something that actually we are still learning about, and different antibody tests give slightly different estimates. We guessed early on, that about 50% are gonna recover and 50% are gonna develop more serious symptoms. So that suggests that about half the people who are who contract the virus are never going to know that they were ever sick. They're only going to figure out later when they have an antibody test. That 50% guess, I mean, I think it still looks a pretty good guess. About half the people who contract this virus seem to develop no symptoms. We're going to say you're in that state for 5 days. That's based on many of these parameters we're going to borrow from an earlier paper by Imperial College, this Neil Ferguson and his team of co-authors. Then if you don't recover, you develop flu, you're more seriously sick. We're going to say on average, you're in that state for 10 days. Now, this is the first place where the age differences are going to show up. We're going to say that 96% of the young, conditional on having flu, are just going to recover. Only 4% of them are going to need hospital care. For the old, those numbers are going to be different. 75% are going to recover, but 25% are going to move into emergency care. So the emergency care state, on average, we're going to say that lasts 8 days. In this state, assuming the hospitals aren't over capacity, 95% of the young are going to recover. Only 5% of them are going to die. For the old, 80% will recover, but 20% will die. So these are based on age-specific estimates for these health transitions from this early Empirical College paper. And these numbers, the duration numbers and the transition shares, those are enough to pin down all of those sigma parameters in those health progression sites. You can compute, suppose you're a newly infected individual, what's the chance that you eventually end up dying of the virus? If you're in the old group, over 65, these transition probabilities are going to imply a 2.5% death rate. If you're in the young group, only 0.1%. So I think these numbers, so far at least, I haven't seen any numbers that are kind of grossly different from these. And they just kind of highlight how asymmetric by age these health outcomes are. You're basically 25 times more likely to die of the virus conditional on being over 65 than if you're under 65. Obviously, there's a lot more variation within those age groups. So a richer model would have more finely disaggregated age groups. And you would see, I guess, below 45 is a tiny risk of death. 45 to 65 is more significant. Within the older group, it ratchets up as you get older and older. The basic and luxury sectors of the economy, we're going to say the basic sector is about half the economy, a little less than half. We went to sort of industry tables in the BEA, and we sort of took a guess at which sectors are obviously pretty basic: health, agriculture, utilities, finance, federal government. There are some other sectors that are pretty clearly not so essential: manufacturing, construction, mining, education, leisure, and hospitality. And then the other sectors, it wasn't so obvious to us whether they're sort of essential or not, so we're going to split them symmetrically with these two other groups. And when we do that, we get, the basic sectors 45% of the economy. The number of the hospital capacity, well, there's different ways of thinking about that, but we have an estimate that basically there are about 100,000 hospital beds available in the United States. And we're going to set this lambda parameter that controls how much excess death we get, so that we get mortality for the old is 20% higher than normal at the peak of the infection. Redistribution parameter, there's only one parameter here, this tau parameter, that controls how costly it is to redistribute. There is a literature in the optimal taxation literature on the what they call the marginal excess burden of taxation. And so the idea is sort of how much resources get burnt up if you try to extract an extra dollar in taxes from people in order to generate more generous lump sum transfers. And one estimate from a survey paper is that if you want to give an extra dollar of transfers to people, you have to sort of extract $1.38 from the people you're taxing. Those 38 cents of that are sort of a deadweight loss. That gives you $1. And if you use that estimate, then the planner is going to want to set the consumption of the non-workers to about 70% of the consumption of the workers. So that's what our planner is going to do before the crisis hits. Every non-worker is going to get 72% of what the worker is getting. The last thing we want to pick is a path for the mitigation path. So how much of the economy is getting shut down over time. We're going to start, we're going to have a 3-parameter function. We're going to start, gamma 0 is going to be the parameter that controls the share of the economy we initially shut down. Gamma 2 is going to control how long we shut the economy down. And then gamma 1 is going to control how gradually the shutdown is eased. And so I lost track a little bit of where I am. I guess I should hurry up and maybe like 5 more minutes or something. Does that sound about right?
That's okay, but we also interrupt you a lot during the presentation. So if you take 10 more minutes, that's also fine.
Okay, thank you. And then we have to decide how important these different sources of transmission are. So there's a nice paper by Mosong and some co-authors that they asked people to keep diaries of what they're doing, who they're meeting, how long they're interacting with people. And they estimate that about 35% of transmission, this is not for COVID, this is for regular influenza, 35% occurs in workplaces and schools. About 19% is in travel leisure activities. Most of the rest is just at home. So we're gonna set it up so that before that thing strikes, about 35% of transmission is at work, 19% is through consumption. How many healthcare workers are getting sick? Well, evidence from a few different countries suggests that's about 5% of total infections are to healthcare workers. So that's going to pin down this beta E. And then there's going to be some basic reproduction number. So the last thing we have to take a stand on is sort of where are we at the start of this pandemic? How many people are infected? How fast is the virus spreading? And it's difficult to do because we don't have many tests. The data is a little unreliable. The best data that we have is how many people have died from the virus. So that's what we're going to focus on. We're going to think of the world as follows. So we're going to say there's some initial new infections landing in the United States on February the 12th. The virus initially spreads fast because people aren't aware that it's happening. Around March 21st, that's the time when various states started locking down. There's a lot of newspaper coverage. So we're going to think that there's a one-time drop in these infection generating rates, alpha W, alpha C, beta H. They're all going to shift down proportionately once and for all on March 21st. That's where people start, for example, taking more care when they go shopping. And at the same time, on March 21st, the government puts in place a shutdown policy and they're going to close half of the luxury sector, which is going to mean half of the luxury sector is about a quarter of the economy. So it's going to mean a 27% fall in employment. The most recent numbers I've seen for the US suggest that employment's actually fallen about 20%. So maybe our shutdown here is a little larger than the one we actually had in the US. And then the last thing we're going to do is we're going to say, well, the levels, there's kind of one level of these infection generating rates before March 21st, a new one after March 21st, and we're going to set those numbers to hit these targets for deaths. So total deaths in the US, March 21st, 340. Total deaths by April the 12th, 22,000. And the daily death toll running at around 1,600 around April 12th. It's now a little lower than that. So we're going to hit all of those numbers. Okay. Now I'm going to show some results. Okay, so the first one is thinking about the share of people currently infected. Now there are two plots on each panel here. The blue is the case where on April the 12th, which is Easter, and I guess Easter around the world, we end this work mitigation on April the 12th, so there's no more shutdown after the April the 12th. I guess that was a policy some people proposed at one point. The red line is the case where we keep half of the luxury sector shut down for 100 days. And so that 100-day shutdown ends at the end of June. So the case where we end the lockdown at Easter, we get a surge in infections. There's more workplace infection. We get a big peak at the peak, about 7% of people are infected, and then infections gradually decline. In the case where we keep the lockdown in place, actually the number of infections gradually declines, but then when we end the lockdown after 100 days, there's a second wave, which is smaller though, of new infections. So these are infections. The share of the old getting infected, you'll notice, is a little smaller than the share of the, fewer of the old are getting infected, more of the young, because the young are the ones who are working. If I look at asymptomatic, it looks similar. People with flu, a little similar. If you look at the share hospitalized, now it's flipped a little bit because the old, remember, even though there are fewer of them getting infected, they're more likely to have sort of negative progression of the virus and end up needing hospital care. So there's a larger share of the old ending up hospitalized. This little horizontal red line is the hospital capacity. So the policy where we end the shutdown at Easter, we get a massive overload of the hospital system, and that translates into a lot more excess mortality. So these are deaths, daily deaths. The baseline policy, with the lockdown staying in place until the end of June, deaths are below 2,000 a day. Actually, in the US right now, they're running at about 1,400 a day. So the model so far, and we haven't really changed the calibration since we did it in around Easter time, the model so far is actually tracking pretty well the red line. And if we look at who's dying, well, even though the old are only about, the old are only 15% of the population in our model, they account for about 3/4 of all the deaths in the model. In New York City, there's some data on deaths by age. In New York City, it looks like about 3/4 of the people who died have been over 65. So our model is sort of very consistent with the age pattern of mortality in the data. This is the share of the population never infected. So by the time the virus runs its course, about a little over half of the population, if the mitigation is ended at Easter, this is the blue line, over half the population eventually get the virus. Only 45% are never touched by it. For the old, a larger share are never touched by it because they don't work, so they're a little bit more protected. The policy where we keep the shutdown in place for a while, we end up in a final steady state where there's fewer people ever infected. Now I'm gonna skip a few things and tell you a little bit about the welfare results. So here are a few different alternative policies. This is our baseline policy, 50% shutdown for 100 days. And these are welfare gains or welfare losses relative to a policy of ending the shutdown at Easter. So it's always the case, of course, that everybody would much rather the virus never came. So the cost of the virus itself, that's always a big negative. But here we're comparing the virus is always there. The question is, do we have a shutdown or no shutdown? If we look at the gains or losses from the shutdown, old, they are strongly in favor of a shutdown. They gain over 2% of consumption from a 50% shutdown for 100 days. The young, they're sort of ambivalent. Their welfare gains are very small. In fact, the basic sector workers, they have small welfare gains. The luxury sector workers, they're the ones who are told to stay home. They have, perhaps close to zero or maybe even slightly negative welfare effects because they're losing income and they lose consumption. If you look at the policies different groups would choose, if they were in charge, they would choose quite different policies. So the old would choose to shut down 30% of the economy. This is the red line. And they would keep the shutdown in place well into the fall. In fact, they would still have some partial shutdown even at the end of 2020. Whereas the young luxury sector workers, if they are in charge, they only shut down 20% of the economy and they end the shutdown much earlier. So there's some big differences in the policies they choose. Now, these are showing 3 different policies. Maybe I should stop after this slide because I'm gone over time a little bit. But the 3 different policies here are the dark blue, as before, is the case where the shutdown ends at Easter and we get this huge surge in infections and hospitalizations and deaths. The red one is the shutdown that ends at the end of June. We get this small second wave. And then the light blue line, the new one, this is the optimal policy. This is the planner that, if a planner, a utilitarian planner was choosing optimally how extensive of a shutdown to have and how long to keep it in place, this is the policy that the planner would choose. So starting from April onwards, it would be shutting down less than 50% of the economy. So this planner thinks that the current shutdown, if you think of that as shutting down half of the luxury sector, a planner in our model would say that's too severe. We should have a more moderate shutdown. But we should not end the shutdown at the end of June, we should keep this partial shutdown in place into the fall. What do we get from that policy? Well, we get a little bit more hospitalizations, infections, and deaths early on. We don't get a second wave. And if you look at the share susceptible, this optimal policy ends up with a larger share of the population never being touched by the virus. So instead of having, say, 50 or 40% of the people remaining unaffected, 60% of the people never get infected under the optimal policy. Okay, I'm gonna let me just show you one last picture if that's okay. Here's one thing we did. I've got some other experiments I could tell you about, but this one I think is kind of a nice one. So far we've been thinking that there are no vaccines in sight, no ways of doing any smarter policies than just shutting down a portion of the luxury sector. But suppose that we are optimistic and everybody realizes that a vaccine is going to become available on October the 12th. We could pick different dates, obviously, but this would be a very optimistic scenario. So October the 12th is going to be a vaccine available. Everybody will be vaccinated on October the 12th. And after that, there's going to be no new infections. So what do you want to do if you know that's coming? Well, the answer is you want to go for a much more aggressive shutdown early on. Because if you know a vaccine is coming, you don't have to wait until, say, the normal scenario is this: you have to the virus is going to carry on more or less until a certain fraction of the population, around 50%, has been infected at some point. You've achieved herd immunity. There's no other way out. You have to achieve some form of herd immunity. If you know a vaccine is coming at a certain date, wherever you are at that date, you're done. The virus is over. So if you know a vaccine is coming, all you've got to do is try and keep infections low until that vaccine arrives. And then you can escape with a very small number of people ever infected and a very small number of deaths. So if you know the vaccine is coming, then you want an aggressive shutdown early on. And you want to keep that shutdown in place until the virus arrives, until the vaccine arrives. Okay, so I'm sorry for going a little over time. I will stop there.
No problem at all. If you want to have the last slides of conclusions, if you have it.
Oh, for sure. Yeah, I can show you. So I say that yes. So the current baseline suggests that current shutdowns, our estimate of the current shutdowns, those should be relaxed a little bit, but we want to keep some partial shutdown in place into the fall. Second key finding: welfare gains from these shutdowns, they vary enormously. So huge gains for the old, very small gains for the young. So we naturally expect some conflict. People are going to disagree about what we should be doing, and that's very natural. If it's costly to redistribute, then you're going to want to have a less extreme shutdown, because if you can't redistribute easily, I mean, maybe this is something that's going to be especially relevant, say, in Chile, for example. Suppose you don't have a system of redistributing easily to people who are losing their jobs, then you have to go easy on the shutdown. You can't have a super aggressive shutdown and no plan for redistribution. That's a policy that's not going to work. And the optimal policy, I should have emphasized this more than I did during the talk. So there are many parameters about which we are uncertain, and they all going to matter for what policy you think is optimal. So one is going to be the value of a life. Obviously, that matters. How important is this economic activity in the transmission of the disease? That's obviously going to matter. How much infection is happening in the workplace? If that's really small, then shutdowns aren't going to help very much. How deadly is the disease? That's something we were uncertain about early on, but I think we're becoming more and more knowledgeable about that. Is a vaccine on the horizon? That's a critical thing, and I guess we're getting better information about that too. It's seeming like a vaccine is on the horizon. We are going to get one eventually, but it's not going to come. I think it'll be optimistic to think it's going to be widely available anytime this year. So those are all things that kind of matter. Thank you.
Thank you so much. So again, if you guys have any question or you want to make any point, please write in the Q&A section your interest to speak, and we will open the mic for you. In the meantime, I'd like to ask one more question, which is about I'm not that sure whether the model naturally accounts for the possibility of people who lose their jobs to do some sort of home production. I imagine, for instance, typically in the US, that especially young, probably, they buy a lot of food and they take it in takeaways and get it delivered. If they're not working, probably they're going to cook themselves and they're going to do some other activities that they don't usually do. That's going to help them to smooth the cost of the shutdown.
Yes, so you could think about that. In fact, there is a paper that I mean, I should have put up a literature slide and I didn't, but obviously an important earlier paper that you might have seen is the paper by Eichenbaum, Rebello, and Trabant. It's more of a representative agent setting, but they're thinking about this optimal shutdown policy. In their model, they have people making a labor supply choice and they value leisure. So if people are staying home more, if they're staying home, they enjoy more leisure. I mean, I think that's sort of a similar thought to thinking about that they could do more home production and get some utility from home production. And we don't have that in our model. So in our model, it's sort of you lose consumption and that's costly. But I agree with that. I mean, I think there are many other things you could think about that would go the other way. So that thought experiment would say, well, maybe shutdowns aren't so bad because people get more leisure or they can do more home production, so the shutdown isn't so costly. But I think there are other extensions you could think that would cut in the other direction. So one thing people are worried about is, well, in our model, as soon as people go back to work, the shutdown ends, output goes back to its pre-COVID level. There's no permanent persistent effects. But you could think that instead, if some firms in the meantime are going bankrupt, workers are losing skills whilst they're sitting unemployed at home. So there might be some sort of more persistent impact of a shutdown. Even once the shutdown ends, they could be paying some costs in terms of lower output for some time after that.
Okay, thanks. There's another question by Sofia Boituco.
Yes, hi. So have you thought about what a shutdown for specific groups would look like? Because right now you have the shutdown that is affecting workers in the leisure sector, right? Yeah. And I know the over 65 don't work, but you have policies that try to reduce the probability of older people getting infected. Like, I don't know, you limit the amount of outings they can do. I know they are very controversial, but have you thought about how that would look? And also policies allowing people that have recovered to work. I know there's also a controversy regarding immunity, but suppose we have immunity, how that would look too.
Yeah, so the second one, we have done exactly that. So we have said, suppose that you could give everybody an antibody test. These antibody tests have become, just in the last month or so, they're becoming much more available than they used to be. And so you could say, well, everybody, you can take an antibody test. If you have antibodies, we're going to assume that you're not going to pass the virus on to anybody else, and you're not going to get infected again. So you are safe to go back to work. And then you would only mitigate the people who don't have antibodies, who might be either susceptible or asymptomatic. So we tried that. We thought that would be a successful policy, but it turns out that actually the policy you want is very similar, and the welfare gains from that policy are really small. You do get slightly better welfare gains when you can exempt all these recovered people, but they're really surprisingly small. And I think the logic is that, well, early on, there aren't that many people who've recovered anyway, because the virus hasn't taken off much. So it doesn't help you much early on because there just aren't that many recovered people who you can say, well, you can safely go back to work. And then later at the end, yes, it's true there are more recovered people, but at that point you don't want to be doing much of a shutdown in any case. So it just doesn't seem like it matters very much. It's not a very useful policy. So I think the key policy that you'd like to be able to do is, there are some people who, the thing you're worried about is people who are asymptomatic. They're infected, maybe newly infected. They have the virus, they don't know it, and they're going to work. And those guys, the antibody tests, as best I understand it, they don't pick up those people. You only develop the antibodies with a lag. So you need a different kind of test for them. And you'd have to test really frequently every day to try and figure out on a given every single day who's actually got those who's actually currently infected. So that's the kind of test that the model suggests you'd like to have. But that seems a much harder thing than the antibody test. So that's your other question was, oh yes, about protecting the old and can we do different things? So we thought, yeah, I guess when people talk about protecting the old, I mean, if the old worked, then yes, you would tell them, please don't work, stay at home. They'll be the first people you tell to stay home because they're the ones who have the most critical health outcomes. But the over 65s, for the most part in the US, don't work, so you don't need to tell them that. I think the ones, if you think about over 65s in the US and probably in Chile and other countries too, there's sort of two groups: the people who are in assisted living, nursing homes, care homes. That group, they're not going anywhere or doing anything. So I mean, you have to take much better precautions than we have taken up to this point to try and prevent them becoming infected and to give them good health care. The other group that's living independently, again, I don't think there's much to tell them because I think they are mostly very aware that this is a potentially very dangerous virus for them, and they're being extremely cautious and staying home. So I guess when people talk about policies to, we need to tell the old something, I'm not exactly sure what we are supposed to be telling them. I mean, it doesn't seem like there's all that much more they can do than they're already doing to stay safe. So that's, I guess my thought. I mean, you could trying to think about the young groups. You could say, well, maybe the under 45-year-olds are very different than the 45 to 65-year-old group. So there you could say, well, I could tell the 50-year-olds to stay home and the 30-year-olds to go to work. You could think about it. Yeah.
Yeah, also for people with underlying diseases, right? Diabetes, I don't know, high blood pressure, this kind of stuff that can be young, but they're more susceptible, at least, to go to the hospital than a healthy individual.
Yes. Yes, I mean, a problem in the US is that if you look at the share of the population that has different conditions, it's amazingly high. It's not like you're not talking about 5 or 10%. It's like half of the working age population is either obese or has high blood pressure or has diabetes or has some other underlying health condition that is puts you at extra risk. So it's actually
half of the working population.
Yes.
Okay.
I mean, I'm sure that you could try and refine it more precisely, and a lot of people have high blood pressure, for example, but there's no high blood pressure and then there's really high blood pressure. So I guess the health guys could tell us which of the groups that are really, really, which combination of characteristics really puts you at the very highest risk, and those groups, try and protect those. But I haven't seen actually too many tables trying to really finally disaggregate by all sorts of different health conditions.
I ran into a paper yesterday. I'm going to send it to you. It's for the UK and it's quite detailed. And it also discriminates between types of blood pressure, types of obesity. It's really cool.
That would be great. Thank you. That would be useful.
There is another question. So we have a few minutes. I'm sorry about that. It's Alvaro Aguirre. Alvaro, you can speak now.
Yeah. Hi, Jonathan. Do you hear me?
Yes, I do. Thank you.
No, it's just a small comment on the distortion that the benefits generates in labor supply. Just just a comment, just to say that in our countries, that the distortion maybe is good because it reduces, it is a kind of mitigation, right? So very poor people that don't receive transfers, they go out anyways and have a very risky behavior. So mitigation doesn't work if you don't transfer income to those families. Just to say that.
Yes, that's a good point, I think. So we have sort of assumed that the planner can tell people exactly what to do, and they have no choice except to do what the planner tells them. But of course, that especially when there's a big informal sector, I think it's very easy for the government to shut down the formal sector, but it's much more difficult to shut down informal businesses. So then it's much more difficult to implement mitigation policy. And I'm not sure how that's yeah, I'm not sure. I'm not sure how that's working in Chile and other countries.
Okay, so thank you very much. We're running out of time. We're hitting the end of the webinar. We thank again Jonathan Heathcote from Minneapolis Fed for being with us, and all of you also for staying with us. So next Wednesday, 11:30, we will have Sergio Correa talking about the lessons from the 1918 Spanish flu. And that's all for today. Thank you very much for coming.
Thank you very much for having me. It was thank you for all the good questions and comments. And I'm sorry if I talked a little long. If you have any extra questions or comments, I'd be very happy to get them. So please feel free to send me an email.
Thank you so much. Bye bye, everyone.
Bye bye.